cardiologist and internist by specialty. He's a consultant at the Aga Khan University and South City Hospital. He is the founder and chairperson board of trustees of the Sina Health and Education Foundation. Welcome, Dr. Asif. Next, I would like to call upon Mr. Javed Ali Jagrani. He is an officer of the Pakistan Administrative Services, currently leading and transforming the People's Primary Healthcare Initiative in Sindh as its CEO. If Professor Javed Akram is here, sir, Assalamu alaikum. We'd like to invite Professor Javed Akram to please join us on stage. Sir, last seat. He is the Vice Chancellor of the University of Health Sciences, the President of Pakistan Society of Internal Medicine. He has served as the Caretaker Health Minister of Punjab, and he's a former VC of ZEBMU and has over 40 years of experience in the health system of Pakistan. I welcome all our esteemed panelists to this session, a very key session and the first session of this Health Expo on the global primary health care and the universal health coverage and where we stand. Pakistan is committed to achieve the Sustainable Development Goals by 2030. And today in July 2025, it is a critical moment to discuss the SDG 3, which is the health goal of achieving universal health coverage through primary health care. The theme of this conference, the Global Collaborations for Better Health, reflects the SDG 17, which is the goal of multi-stakeholder partnership. With this preamble, I would like to request Professor Javed Akram Saab. Sir, from your vast experience of academics and the health system, please enlighten us on the lacunae and the bottlenecks in the two key areas, the health policy and the curriculum. The National Health Vision 2025, what it was able to achieve, the upcoming National Health and Population Policy, how it will help us achieve the SDGs, and the impact of devolution, especially in the context of the curricular reforms required for bridging the HR that can support us in establishing the universal health coverage.
एक ही पॉलिसी को आगे इम्प्लीमेंट करे, बजाय इसके कोई नई पॉलिसी बनाए, पहले अंडू करे। तो मैंने उन्हें कहा कि जी आपने ही ये ऑल पार्टीज कॉन्फ्रेंस कराई थी टेररिज्म की, और तब उसके खातिर रिजल्ट आए थे। अब आप ही ये मीटिंग बुलाएं तो वो हंसने लग पड़ेगा, ये तो हमारा काम ही नहीं है। मैंने कहा जी काम तो आपका है या नहीं है, लेकिन आप ही कर सकते हैं कि ऑल स्टेक होल्डर्स, ऑल पार्टीज, ऑपोजिशन, गवर्नमेंट, everybody, army themselves, because they are in government also, so we should all agree to a health policy, irrespective, और 50 साल की health policy दे दें कि जो आए अपना हिस्सा डाले, उसमें चेंज ना करे. So that is the only way I think that Pakistan should go.
Thank you, Dr. Javed. In the interest of time, I have to cut you a little short. So wonderful points by Dr. Javed Akram, that policy is really not the problem. It is mostly the issue of implementation, and short-lived policies do not work. They should be long-term policies which should be applied across the country by all politicians and all governance that come in. Next, I would like to request Dr. Khalid Shafi Saab. You have been spearheading many public health initiatives on your platform of the PPA, and especially in the childhood immunization category, and as the chair of the mark-e-haq. So what are some of the main health and social issues that are causing these not so good indicators in child health, and how our current immunization program and the upcoming vaccines can achieve universal immunization coverage? And one key question is, what is your expectation as chair of mark-e-haq? I would like to ask you, what is your expectation for polio and measles eradication in Pakistan? This is a very key thing.
Thank you. You have asked three things each of which needs special attention and answer. First is the health indicators. Regarding the health indicator, although there is some improvement in the health indicators, our physical age has now in the 60s, it was in the 50. Our infant mortality rate was 126, now it is in the range of 67 and 80. Lekin, in spite of this, the rate of progress is not proportionate to the efforts. First of all, the efforts are only done in the curative side. our health policy, health budget is mainly directive towards the curative side. Look at the budget of the Sindh in this year. Out of 350 billion approximate budget, only 16 billion is allocated to PPHI. This approximate figure, which covers 70% of the primary health care of the Sindh. And only one hospital, SAUT, is given 18 billion, Indus is given 10 billion, a new hospital is built with 10 billion Larkana, and there is so much distribution of the funds all around. But for the primary health care, which is the basis of the health foundation, is so much neglected. Number one part is that. So, Dr. Javed Akram has rightly said that the government and the leaders are only interested in achieving the things. Today, if you immunize a child, the benefits will be evident over the next 20, 30, 40 years. If you counsel a mother about the breastfeeding, the result will come later. But if you make a heart transplant, kidney transplant, it will be very attractive to the people. One thing is that. So our health indicators are not improving as they should be. There was a plane crash of the PIA 2-3 years back. Now the people still remember. There is a plane crash of the Air Blue and other airlines, people remember. But daily, equal to 2 jumbo jet passengers number, children are dying in Pakistan. But attention is not being given to that. We have prepared a costed action plan for the newborn survival. Government has, Dr. Javed has rightly explained everything. We worked 2 years for making a strategy for improving our newborn mortality, which is the worst in the world. But the costed action plan is there, but it is not being implemented. Still, the government main focus is on the curative medicine, which gives early results, but this primary health care foundation will give later results in a long run. So, this is a neglected part. This was your first question, and the second question was, remind me, that was about the immunization. Okay, the main issues which call, number one is the lack of the civic infrastructure. For example, I give you an example. When this rotavirus vaccine was introduced in the EPI program, we were very hopeful that now the hospital will not be treating so many patients with the diarrhea. But still, our lack of infrastructure, good hygiene, sanitation, safe water, it is not being complemented with that. In the Western world, they have achieved attention on the health issues plus improvement in the civic infrastructure and the hygiene and the safe water, etc. This is a total ignored part. Our first priority should be to provide the safe, clean drinking water to our people. There is no plan for that at all. Even the water is not there sufficient. So one factor is that. Other factor is that I have just explained that we are curative minded, not preventive minded. Second factor is from the other side, that is a demand. That is demand. There's so many good programs are there, but the people are not availing then because of the number one, poor literacy rate, lack of awareness, and lack of the sense of the health education. For example, vaccine program is there. The government purchases vaccine for every newborn who is born in Pakistan, but the utilization is less than 70%. There are other factors for that. Our misbeliefs is still, we have so many misbeliefs that of the people, we go door to door for the eradication of the polio, but the people refuse for that. So, one thing is that, now coming to that, what is our expectation about the polio program, polio eradication, the measles elimination? Regarding if we take the program as a polio control program, this is a very successful program because there are very few cases of polio. But for the eradication, which is an absolute process, we have to go far beyond this. So much energies and so much funds are being allocated to polio program. Even the Prime Minister, Chief Secretary, everybody is committed. The Commissioner, Deputy Commissioner, Assistant Commissioner, Police Force, everybody is supporting to this program. But because of the misbelief of few thousand parents, still the virus is circulating. But still, we have no option. We have to eradicate the polio because the whole world is looking after us. And we have no this option that we can ignore this. It's about the polio. Second is the measles. Measles is a killer disease. We, the pediatricians, know very well this is the worst of all the vaccine preventable diseases because it has significant incidence. Unfortunately, it can be easily prevented just with 2 doses of the vaccine. First dose is given MR vaccine at 9 months, second at 15 months. But our coverage, which starts in the range of 80-85% at birth, drops to less than 70% by the 9 months of age. And this figure is complemented by the high vaccine coverage rate in the Punjab and Azad Jammu Kashmir. If we come to Sindh, it is 69%. If we go to KPK, it is 60%. And if we go to Balochistan, it is 29% coverage only. So, but the situation is so disheartening on one side. On the other side, it is not that we, the health provider or the public health specialist, we have not given up. We are still raising our voices, and whatever places at the policy level we are working, we are trying best to overcome this situation. I give you just this example regarding the NITAC. NITAC is not an executive body. It is a group which is formed by the government of Pakistan to give the policy guidelines regarding the immunization to the EPI and the Ministry of Health. Regarding in my tenure, in the last 2 years, as a chair, what we have achieved, number one, on the top of that, we have included human papilloma cervical cancer vaccine in our EPI program. This is a great gift to the female children of Pakistan. Every year, 5,000 women who are suffering from the cervical cancer die because of that. We will be saving their lives. This is a great achievement, and this HPV will be rolled out in the Punjab, Sindh, AGK, federal area on the 15th September. Every female girl from 9 years to 14 years of age will be given this vaccine. And from the 1st January 2026, it will be included in the National EPI program. In the start of the 2025, KPK and Balochistan also will have the similar campaign. This is one achievement we have done to overcoming the measles, this so much high rate of the incidence of the measles. There are many suggestions. At an ad hoc process, we are going to have an SIA, special immunization activity in the November, where all over the Pakistan, we will be vaccinating the children from the 6 months to 5 years of age. So,
it's 2 p.m.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
Healthcare Expo and Conference लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zuhair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश या एग्जीबिशन नहीं है, ये एक सोच है, ये एक सफ़र है जिसकी बुनियाद डाली जा रही है. और हेल्थ केयर एक ऐसा सब्जेक्ट है कि इसको समझने की और इस पर अमल करने की ज़रूरत है. तो मैं ज़ुहैर नसीर साहब आपको और आपकी टीम को बदर सॉल्यूशन को खराज तहसीन पेश करता हूँ.
Assalamu alaikum ji. I'm really grateful to the organizers for having this very important session on patient safety. Something which is very close to the heart of everyone who is concerned with medicine, deals with medicine, either in the form of a professional doctor, a medical professionalist, or regulatory bodies like DRAP, or those who are in the process of making medicines like from the pharmaceutical country. So, very important factor which involves all of us equally. So, patient safety is one thing that we feel, and I personally feel, is not given that much significance and importance in our country as it has been given to anywhere else in the world. So, at times, I myself being a practicing surgeon, I know when I was working at the JPMC Jinnah Hospital, or later on I'm working in the private sector now, that patient safety does not come as one thing that we should be taking care of as the first step. And that is what we want our new generation of doctors who are coming up, that they should be aware of that. So a panel which represents almost everyone from physician, Aftab Sahab, from surgeons, to those who are in regulatory bodies, from PharmU, and those also who are from the hospital side, like Nashwa is from the South City Hospital. So let's start. I'll start you, sir, Aftab Sahab. What structure and cognitive factors most commonly contribute to the diagnostic errors that we make? And there are a number of diagnostic errors we all know. And how can healthcare team, not an individual, proactively mitigate them? What do you think? What do you think how it could be done?
I think the first thing to do would be to define diagnostic error for the sake of the public. And diagnostic error means when you cannot make the right diagnosis, or you miss the right diagnosis, or even if a diagnosis is delayed, that is also called a diagnostic error. And if even the diagnosis is correctly made, is made in time, and is not communicated to the patient in time, even that is a diagnostic error. So in US, about 12 million diagnostic errors took place 2 years ago in 1 year. And they were responsible for a number of deaths. Diagnostic errors, they come under the ambit of medical errors. And the medical errors were first highlighted in a report of Institute of Medicine, which was published in 1999. So, I personally believe that these occur because we do not do what Sir William Osler asked the modern day physician to do. And he was a professor at University of Pennsylvania in 1905, beginning of the last century. And he said, listen to your patient. He is telling you the diagnosis. So unfortunately, we are more focused on clinical decision support systems and artificial intelligence, whereas in many prospective studies we know that the correct diagnosis can be made in about 75% cases on history alone, 6 to 7% on examination, and 13-14% on investigations. So if we employ the right history, spend quality time with the patient, examine, and become a thinking doctor. One important thing is, as we become senior, we stop at times to think and do things reflexly. And that contributes to diagnostic errors. Once the diagnosis is incorrect, then it erodes the trust. It jeopardizes the outcome of the patient. It causes extra burden on the cost. Medical errors, sir, are responsible for an additional cost on healthcare of $50 billion per year. So this is all preventable if we start with the right history, spend time with the patient, and if we have systems in place. Unfortunately, when we are overburdened with patients, we do not have systems. So first is the cognitive problem, that the physician herself or himself is at fault. Then are the systems. अब वो हमें कहते हैं कि जी EMR इलेक्ट्रॉनिक मेडिकल रिकॉर्ड होना चाहिए। आप बड़े बड़े ओहदों पर रहे हैं माशाल्लाह, and you have headed so many institutions, and now you are at the helm of the policy making in the province of Sindh, and with the status of a minister. So you should know that these doctors, EMR requires time. If you go to US and UK, a doctor is supposed to see only a maximum number of 10 to 12 patients in one day, because it takes 30 minutes to register the patient on EMR. तो एक तरफ एक्सपेक्टेशन है कि EMR हो, दूसरी तरफ नंबर ऑफ पेशेंट ज्यादा है। फिर हम जब मांगते हैं एज अ फिजिशियन सर, वी आस्क फॉर डेटा एंट्री ऑपरेटर, तो वो कहते हैं नहीं ये आपने खुद करना है। तो बड़ी ही एक डायलेमा है। फिर दो चीजें और हैं, विद परमिशन ऑफ द चेयर आई वुड लाइक टू हाईलाइट, जो डायग्नोस्टिक एरर में सिग्निफिकेंटली कंट्रीब्यूट करती है। एक है हेल्थ डिस्पैरिटीज, और आपसे ज्यादा कौन अवेयर होगा कि जब मरीज आता है हॉस्पिटल में, तो वो लोग जिनको सबसे ज्यादा जरूरत होती है केयर की, दे एंड अप रिसीविंग द लीस्ट केयर। आई विल हाईलाइट few example. People who inject drugs, doctors, most of them look down upon them, ऐसे जैसे वो कोई जुर्म करके आ रहा है। वो तो बेचारा ड्रग एडिक्ट अपनी मर्जी से नहीं हुआ है, वो तो आपकी शफकत और मोहब्बत चाह रहा है। People who are left unattended, people who are poor and marginalized, people who are mentally challenged, people who are old and who have multi-morbidity, ये सारों को ज्यादा जरूरत है, और प्रिजनर्स, लेकिन इनको कम मिलता है। तो एक ये भी वजह है डायग्नोस्टिक एरर्स की और मेडिकल एरर की। और सर एक और वजह वो है ये सिस्टम कोई इंसेंटिवाइज नहीं करता, या कोई अच्छा काम कर रहा है या बुरा काम कर रहा है, वो सब के लिए बराबर है।
Dr. Naveed, continuing with what Aftab sir ने बताया in a very, very nice, elaborative way, what errors are. Don't you think, as he has said, that right now we are emphasizing more on the diagnostic tools rather than applying our knowledge of medicine in the form of history taking, examination, which our professors used to emphasize a lot. And they were of the view that, as he has very correctly said, that majority of the diagnoses are made on that. Today, हम या हमारे साथ जो लोग हैं, because of the availability of CT scan, MRI, so many things, the first thing we do is when the patient comes with a, for example, a headache, MRI करा के आते हैं। Now taking an easy way out to diagnose, because we have got so much rush, we don't want to examine him properly for that. आप क्या समझते हैं, does it contributing to diagnostic error, and how can it be overcome?
Sir, thank you very much for giving me a chance to collaborate myself on such an important topic. So you are very right, sir. Said a very important sentence in the beginning that listen to the patient, he is telling you the diagnosis. So I personally feel that one factor is the patient's workload, because a doctor has to see a lot of patients in 3 to 4 hours, and the patient expects that the doctor should not only listen to him or her, he should also examine her and him and then prescribe the relevant investigation. But I personally feel, sir, keeping in view all these limitations, they are there, but one link is definitely missing, and that is we do not touch our patient. That sense of touch, like we talk of the sense of touch between the mom and the baby, exactly the same relation exists between the patient and the doctor. This link is missing, and how we can re-establish this link, I don't know, because the patient to doctor number is too much. But I personally believe that this factor should be addressed seriously, and this should not only develop the patient-doctor, strengthen the patient-doctor relation, but it also decrease the workload on our investigations. Like, number one, the patient expects a doctor साहब को test ही लिखा, so doctor writes the whole battery of the investigation, including chemistry and radiology and everything. But if we start doing that, and if we start developing the rapport with the patient in terms of detailed history and clinical examination, and then full explanation to the patient, because once the patient leaves the patient, office of the clinician, he's I don't know, मुझे तो नहीं पता डॉक्टर साहब ने कि मुझे क्या मसला है. So we should properly explain the patient, and it would definitely decrease the workload on our investigation to better investigation. As sir mentioned, I was reading a few days back, because it would also jeopardize the number of patients. It would also jeopardize the patient safety as well, which is our prime topic today. And recently I was reading an article in which it was mentioned that the number of deaths in USA, because USA and UK, they are the icons for us. We read the books written by their doctors, and it counts around 2 lakh a year because of the breach in the patient safety chain. And number two example of UK, the NHS budget rose almost to 40% in the last 1 to 2 years. So I personally believe, sir, highlighting the very true topic of this age, the number of patients is the main cause that our diagnostic battery of investigation is rising, and we are missing the link between the patient and doctor, because we cannot explain to him, we cannot examine to him.
Samad Sahab, ये बताएं कि because you are in digital, which is the latest thing like AI and other things the companies, do you have any solution for the problem that has been raised for overcoming these diagnostic errors? Do you have that? Not only relying upon the diagnostic tool, because once the tool goes wrong, the whole management will go wrong. So, do you think that the recent trends that you were just talking about, bringing up together, can they be of any support in overcoming this decision making of a diagnostic tool not to go wrong?
Assalamu alaikum. Thank you so much, sir. First of all, we at Digitrends currently working on the AI solutions which we think can make a difference in patient safety. I will give you for example which I think is relevant, how AI and IT can make a big impact on patient safety. First of all, we are going to integrate it with our EMR solution. So currently in the conventional EMR, if doctor enter the wrong medicine, or if any medicine which is not suitable for the patient, he has the allergies or some kind of histories, doctor cannot go through all the EMR details every time, and he can enter wrongly some medicine which may affect the health of the patient. Our AI system can be integrated with the EMR, and it can, in the real time, stop the doctor that do not enter that kind of medication that can be harmful for the patient. This is the one example, and there are many other features which can be very helpful when AI will be integrated into the current AMR solution. The second example would be, we are currently working on the world first FDA-approved wearable ECG device. So currently what is happening, when the device is taking the ECG of the patient, it is transmitting the data to the mobile application, and that mobile application submitting that data to the doctor, who is actually manually reading the ECG, and then he is diagnosing and prescribing the medication over his whatever he sees over his diagnosis. Now, if we integrate AI into that in between, where doctor is currently diagnosing or checking the ECG, the AI system can do this automatically, and he can suggest, the AI can suggest either the patient needs immediate attention of the doctor, so it can send the ambulance, or through telemedicine, doctor can connect to the patient directly. So if we will integrate AI agents into this hardware monitoring system, healthcare hardware monitoring system with the patient and doctor, that AI can do the job of the doctor, the initial job of the doctor. So it can be make great impact as well. The third thing is that differential diagnosis tool. We are partnered with the leading differential diagnosis tools such as Visual DX. So we integrated that Visual Diagnosis. We launched that differential diagnosis tool here in Pakistan, we saw a very good adaptation on AI on that tool. If you take a picture of your skin region, the AI image recognition system can recognize either it's psoriasis or eczema through the thousands of images which is already stored in the database of the AI. And doctor who may know, maybe he cannot diagnose that this is the early stage of psoriasis, AI can detect it in a very early stage. So these are the 3-4 examples which I think, and this is already happening in the world. AI has been integrated. The question is, we are not only trying to implement and integrate these solutions currently within this Pakistan market and in Saudi and in Dubai. We are also taking care how the AI governance and how AI compliances can be a part of it. So it can be implemented. Again, it's related to patient safety also. So I think AI will make a great impact, inshallah.
Thank you. Dr. Mema, my question to you, because you're also associated with the pharmaceutical, what prescribing safeguards are there for effective avoiding any prescribing liquidity or anything that can be a wrong prescription because you're associated with the pharmaceutical? What safeguard the pharmaceutical has done to them? For example, I can give you a number of medicines with a similar name, similar appearance. In cases of an emergency, sometimes the does pick up the wrong one, and it may be illegal for the patient. So, what are the safeguards that the pharmaceuticals taking in order to avoid these prescribing?
All right. Thank you so much. My name is Umema. Thank you for inviting. I'm representing a pharmaceutical company here, but I also hold a position for a primary healthcare setup here in Karachi. So I have kind of an ambit or a cap of both, say it from a pharmaceutical perspective and from the hospital end as well. And there have been a lot of solutions that आपने AI की बात करी, and there are a lot of integrations. And same goes when it comes to patient safety, and we talk about what systems can be implemented in pharmaceutical companies. But before I can actually talk about what should be done, I'll be talking about a patient safety culture. And there is a small presentation, if you may all allow me to give a small presentation of the magnitude of patient safety which we are talking about, especially here in Pakistan. So, sir, if you may allow, I'll just give a brief presentation. It's hardly of 10, 11 slides.
So we can just discuss that now. We can give us a brief description about that.
I'm sorry?
We are running short of time, so...
Okay. All right. So I'll just make it very precise. See, for me, when it comes to ADR or pharmacovigilance, or we talk about reporting system, the first thing which has to come is to start reporting. We do not hold here a culture of reporting. DRAP already has established systems in which the healthcare providers and the people who are in the pharmaceutical companies are encouraged to report any ADR which is reported. And I'm talking about the drug reporting errors. I'm not talking about the medical errors, jaise Dr. Saab ne initially kaha, that also comes under the ambit of medical error. But unless and until we do not know what is being reported and what are the root causes of it, how are we going to actually establish systems in our areas to counter that? And I'm sorry, I was not able to listen to your specific questions regarding pharmacovigilance.
Regarding the drug we use, for example, recently, DRAP has withdrawn a syrup because it was causing a lot of complications. Many medicines are withdrawn. So what pharmaceutical industry is taking care of avoiding those errors to take place when you are manufacturing a medicine? What are the protocols that you follow? Are there any protocols?
Yes, definitely. See, pharmaceutical companies, especially in Pakistan, I would consider this is the most regulated industry in Pakistan. And it has federal regulations applying to it as well as the provincial ones. So there are systems established. Say, for example, I'd give, an example of LASA, which is called as the lookalike enzyme villi, which is the major, one of the major causes of, wrong administration or wrong prescribing. And there is a whole system established by pharmaceutical companies, especially the MNCs as well as the local pharmaceutical companies, they have established systems in which they do have protocols, and especially with the integration of AI into such systems, we are able to check that. And similarly goes with the names. But unfortunately, I would refer to the recent cases of Avastin, as we all are well aware, the case of ceftriaxone, we already know that. But these were malpractices of administration rather than something which was falling under the pharmaceutical category. So the indications are, of course, devised.
Thank you very much. Nashwa, you are related to a hospital, a major hospital in the city. So what do you think in a hospital? We all know there are so many cases reported, so many errors take place. We at time life-threatening to the patient. Patients have lost life. So do you think, what are the major protocols that could be applied, or what are the systems that need to be in place in order to avoid all that what is unfortunately happening if patients are being mistreated or being misdiagnosed or whatever you say, which is harmful to the patient whenever they come to the hospital? Any protocols or systems that you think are there, or you will suggest them to be applied?
Ji, Assalamualaikum. Thank you, sir, for having us. Thank you for having us. So I work very closely with a lot of workflows with different kinds of healthcare providers, be them physicians or nurses. Now, in terms of reducing harm, there are different components to how you can reduce harm based on who the provider is. जैसे हमने आज की discussion में देखा है, the physician's perspective or the surgeon's perspective is very unique and different. They have different goals for the patient, be it their assessment, their diagnostics, the treatment plan. That is a vision which is dedicated to the physician. Where safety falls in, where measures fall in, where systems fall in to reduce harm in that pathway is separate. That is something that is addressed separately, that has different patterns, different safety measures. If we're talking about surgery, for example, something which may seem like a very simple process, but starting from when the moment the patient arrives in your clinic, what is being communicated, what is being documented, what is going on the record, what does the patient understand from everything the surgeon is saying? And in the event of a harm happening, was that harm pre-warned, pre-informed to the patient? Was it uninformed to the patient? What are accountability measures in place for the surgeon or for the providers? So, surgeons, for example, nursing is a completely different game. Nursing ka role is absolutely separate. They are more involved with the hands-on care of the patient in a time which is vaster than it is for the physician. How to reduce patient falls, how to prevent the patient from getting harm from regular activities while they're in the hospital setting, during mobilization, during eating, to prevent aspiration, for example, to prevent medication errors. What is the process of the medication cycle? Uske humne kaun se metrics, accountability tools rakhe hain to make sure medication is being given safely.
Also, being a physician, there are a number of times we are prescribing a medicine. A patient has got a problem. He says, for example, full factor deficiency, I have got epilepsy. And when we are prescribing a medicine for that, not for that, for other reasons, we at times do not know whether this medicine will be harmful to that or is contraindicated to that. So at times we miss, because no doctor can have knowledge about every disease and what medicines are contraindicated. Do you think the use of e-prescription could be effective in that, or still the use of our own intelligence in that will be more effective?
I think, sir, you have rightly pointed out, electronic medical record or e-prescription can help reduce it, but it cannot eliminate it. Healthcare industry is supposed to be an industry which is far less regulated than many other industries like flying industry. People who are flying jets and airlines, they are far more meticulous in their approach, whereas the number of people suffering at the hands of medical error is far more. In USA alone, medical errors have become the third leading cause of death of them, there are 250,000 every year, half of them are preventable. And sir, 250,000 makes it about 680 per day. That is like 1.5 jumbo jet going down every day. And look at the time, look at the method, look at the money that is being spent on airline safety compared to healthcare safety in our profession. So something we are doing is absolutely wrong, and it requires a paradigm shift.
So what do you suggest? Like, as we have very correctly said, there are a number of prescribing errors that we are making. Even the most senior ones make an error in prescription, and they miss on the history of the patient because EMR is very good, it's a new thing. But practically speaking, as we have been working in a government sector hospital, the prescription when you write a government sector hospital in an OPD with 300 patients standing and you have to pass within 3-4 hours, it's not possible to go for an EMR for each one of them. Either it should be a limited number of patients that we have seen, but we are seeing an uncounted number of patients. उस कंडीशन के अंदर what do you suggest, what protocol or what safety measures could be undertaken कि आप either it should be at the end of the prescribing doctor or the pharmacy which is issuing should take care of that when the pharmaceutical after prescription जाए that this drug should not be given to this patient or the dosage is not correct. What do you think? How could it be counteracted?
I think, sir, you have highlighted the issue in your own question that it cannot be anyone working in isolation. What we are doing right now is working in silos. Physician working as a physician, pharmacist working there. EMR, I don't think is going to be the solution in Pakistan. There are two things. I am an old school. I believe that if you spend quality time with the patient, that not only builds trust, it also ensures patient safety and it also ensures quality care to the patient. But at the same time, we have to think differently. The money cannot go to the armed forces of Pakistan and our patients deprived of their due rights. ये कहाँ पर होता है कि 1% GDP से भी कम हम एजुकेशन और 1% से कम हेल्थ पे खर्च कर रहे हैं. This thing will have to change if you want to change or contribute. अमेरिका में वो कहते हैं कि हम 2,50,000 लोग हमारे मरते हैं हर साल और वो कहते हैं कि 3 मिलियन लोग मरते हैं दुनिया में हर साल. पाकिस्तान में तो रिपोर्ट ही नहीं होती. India में 54 million medical errors take place every year, which is humongous.